levels of government of vaccine eligibility have dropped now down to 18. But although this is increasing the numbers of people who are receiving the vaccine, it's very important that we don't forget those people who have not yet received the vaccine in the different age groups, in particular the older age group. And I think by now we're all very aware and all very familiar at the levels of vulnerability experienced by those people who are 60 plus. And we need to focus on this group as well as the groups as we roll down the age groups. And I think what we need to ensure is that government works with all of community and talks to all of society in confidence, getting buy-in in a well-coordinated communication campaign, which is necessary to ensure the good uptake of vaccines offered. We have got to speak to government, we've got to speak to other research stakeholders, we've got to speak to academics, we've got to speak to people in marketing, we've got to speak to people in funding. And I think that's why we've got a particularly exciting group on this call. We have research represented, we have social communication represented, and we have the funders represented. So working with all of these, we need to see what is happening in our vaccine uptake. Are we calling it vaccine hesitancy? Are we talking about vaccine inertia? Are we talking about barriers to access? What are the issues related to the trust of the vaccine, the side effects of the vaccine, and accessibility of getting the vaccine? So we would like to take this opportunity to work with media and other key stakeholders in this webinar to work out find out what is going, and to redirect and share the government communication strategy in order to respond to challenges that are bigger than just vaccine hesitancy. I don't believe that South Africa is a vaccine hesitant country, but I think there are issues that impact on or limit or prevent people actually getting the vaccine in the arms. So what we're going to be looking at, key issues of discussion this morning, is we're going to be looking at research findings on public perception and sentiments about the government's rollout plan with a specific focus on hesitancy and acceptancy. We want to look at the emerging challenges which are being highlighted by various research, other than just hesitancy. It's not a case of necessarily anti-vaccine. It's what is actually going on. We want to outline how researchers inform the communication strategy and highlighting of the government communication efforts. We want to showcase some of the government communication material and initiative the government is using. And we'd like to share our finding and our experiences with the public and with the media on this call. So I would like to take this opportunity to just welcome again the DG, Ms. Pumla Williams, and to ask her if she could give us her opening address. Thank you, Ms. Williams. Ms. Williams, are you there?
Yes. Can you hear me?
We can hear you and we can see you. Thank you.
Okay, thank you. Let me go back. Program Director, distinguished panelists, members of the media, esteemed colleagues, let me take this opportunity to welcome all of you today as we explore the importance of research in guiding communication. Today we will be sharing key research. Sorry, I'm battling with my notes. Okay, sorry. My screen froze, but let me start by also welcoming all the esteemed colleagues that have plugged in, the members of the media, today as we explore the importance of research in guiding communication. Today, colleagues, we will be sharing the research insights on public perceptions on our vaccine rollout communication. Our discussions today will be vital as we set out to draw more South Africans into our national vaccination program. We have convened today's webinar under the theme, I quote, "Value and Importance of Scientific Research, Evidence, and Data," as we explore the effective communication on COVID-19 vaccination rollout. This theme seeks to allow us to better appreciate the targeted communication approach we undertook. It allows us to appreciate the communication complexities as we confront the vaccine inertia and how we can take the message to all South Africans. Our communication system, spearheaded by GCIS, plays an important role in keeping South Africans abreast on developments in the fight against COVID-19. In the early days of our fight against COVID-19, we had to deal with communicating about an unknown virus. We had to traverse a heightened communication environment as we sought to educate and reassure South Africans that were anxious. Today, our communication is focused on supporting the biggest vaccination program of our country as undertaken. We have activated national, provincial, and local communication systems to take the prevention and the vaccination message far and wide. Our work is in the realization that we need to ensure we take society along and get their buy-in through a well-coordinated, massive communication campaign. Our communication on the vaccine rollout is guided by a progressive and well-researched communication strategy. It is a multifaceted strategy that covers all aspects of the nation's vaccine rollout. It is guided by the political leadership through the Interministerial Committee on Vaccines and the National Corona Command Council. The messaging is guided by the scientific evidence and shaped by key research insights on how South Africans view the COVID-19 vaccine. Program Director, our work in communication is not merely based on a whim. Since the onset of COVID-19, communication has been thrust into uncharted territory. In the complexities presented by the COVID-19 and the ever-changing communication environment, research has enabled us to navigate our communication approach. Research has ensured our communication is deliberate and targeted. The GCIS Research Directorate has provided us with key insights that shaped our communication plans. Our regular communication impact report, which assesses the awareness of the COVID-19 messages and the preferred platforms used by different strata of society. Based on these assessments, our strategy has been regularly amended accordingly. For example, through some of the research findings, we have been able to address the information gap in some of the rural communities. And in this place, I have to indicate that some of our core communicators and community development communicators on the ground have been consistent with the findings that have been provided to us by the research. As a result of some of the feedback we get from the ground and the research, we have been able to shift our focus to intensify communication in rural communities using the platforms that they prefer in the language that they prefer. We crafted messages that resonated with their respective audiences. Our research team has also undertaken a triangulation of all the research on vaccination to review insights coming from these different research studies. This was to determine some level of alignment with regard to the findings to date. The research has revealed the vaccine inertia, the trust of the vaccine, adverse reported events, and the accessibility of the vaccination sites in communities. We found that while vaccine willingness was relatively high at 62% among South Africans, 11% were unsure and 28% were unwilling to receive the vaccine. These insights helped us to streamline our communication, address the fears about vaccine side effects, lack of trust, and the safety, and address the various myths that circulated on social media. This was complemented by engagements with experts via the webinars that we organized, community radio phone-in programs, which we found quite effective, using some of the local medical practitioners and also community leaders, and the media roundtables, which have strengthened the conversations through the radio talk shows. We also implemented targeted interventions for specific groups where our research findings showed a lower participation in the vaccine rollout, such as men over the 50 years across all segments. Our research further provided insights into who were most trusted by communities. Citizens wanted to see their leaders vaccinated before they could trust the vaccines. These key findings enabled us to get a number of provinces to publicize the vaccination of their premiers, influential leaders, community leaders, traditional leaders, and generally influential people in their respective communities. Ladies and gentlemen, as government, we have relied heavily on the media since the onset of the pandemic. Our media colleagues have joined us on the front lines and have borne the brunt of the pandemic firsthand. Throughout this unprecedented period in our history, we have worked hand in hand with the media to keep the nation informed. It is not an over-exaggeration to say that the media has played a pivotal role in keeping our nation safe, and more recently, tackling the myths around vaccine through respective talk show conversations and inviting specialists to begin to talk around the myths that have been circulated in the social media. If we are to turn the tide against this pandemic, we need to deepen this cooperation as we take our message to all South Africans. The role of media is ever more critical, as our research shows that television and radio are two platforms with the highest level of recall, followed by the word of mouth and social media. We have found that South Africans receive their information mainly through television news, radio news, and current affairs. This makes media a vital partner in spreading the important life-saving message that COVID-19 vaccine is our best defense against the virus. It prevents serious illness, hospitalization, and death. We need to continue to spread the message. The more people we vaccinate, fewer people will remain vulnerable to being infected with a serious illness. Whilst all platforms remain important in our integrated communication approach, media plays a critical role in engaging with many conceptions and skepticisms on vaccines. We continue to cherish the working relationship we have with the media. Let us continue to spread the information around the vaccines provided by the Department of Health and the experts and the World Health Organization. Through your work, we continue to ensure citizens make an informed choice rather than acting out of ignorance or misinformation. We call on our media colleagues here today to use their influence and reach out and share positive vaccination stories. In conclusion, Program Director would like to say that the value of research in shaping communication cannot be overemphasized. Our research insights have played a critical role in our communication interventions. It has also brought a number of issues and challenges to the fore that have shaped us in the problem solving. We have been able to better engage with citizens on this important national issue by understanding their beliefs and their concerns. It has allowed us to create greater alignment between our citizens with our messaging. We appreciate the valuable information we have received from our researchers. We remain convinced that through providing communities with the right information, they will be able to adopt an informed choice to go and vaccinate. The vaccine rollout has already opened for the over 18 years old. We call upon them to go to their nearest vaccination site and get their VJab. Together, we can continue to build the momentum and vaccinate as many people as possible to prevent serious illness, hospitalization, and death. This will ensure we get our country back to normal and continue to grow the economy and create the so much needed jobs. I look forward to the deliberations today, which will further entrench our belief in research as one of the critical tools to communicate. Thank you.
Thank you very much, DG. And just to pick out, I'd like to pick out three very important points that I think you've raised. The one is the importance of research. But as you said, the need for research is to create communication that is deliberate and targeted. And this is exactly where we need the research to inform the work that we're doing with people. And I would like to, again, to go to your point about the media and the vital role of the media here, because it is with the media that we communicate with the country and with people in the country. And the third point that I think you raised, which is so important, is that, and this brings it all together, is to give people the opportunity to make an informed choice or an informed decision. So working with research, working with scientists, working with the media, we can all together give people the information that's needed to make an informed choice or an informed decision. So thank you so much, DG, for your time, and thank you for your introduction and your thoughts. Can I ask Ms. Radamir Andrea, I'm just going to do your introduction, if I may. So Andrea is the CEO and founder of Ask Africa. She is a female entrepreneur and has gained success with global recognition as a leader in her field over the last 25 years. She sees business as playing a pivotal role in shaping and changing society, and she's committed to that change through uplifting social voices. Her commitment to honoring the voice of South African citizens is born out of an enduring passion for all things socio-political. So Ask Africa has been founded in social research, and this drive is still evident in the weekly COVID-19 measurements directed by her thought leadership. She is an acclaimed conversationalist who's respected for integrity, love for eccentricity, and well known for enjoying life to the fullest, having taken the front seat on the roller coaster of life. And having worked in a number of forums with Andrea, I know she's also taken the front seat on helping to work with addressing COVID. So Ask Africa is known for its innovative methodologies and decisioneering. And Andrea is serving currently on 3 COVID-19 MAC technical committees. The Ask Africa COVID-19 tracker is her passion and a contribution to our country during the corona trauma. She's registered with a number of organizations and is a research psychologist with the Health Professionals Council South Africa. So, Andrea, I'd like to welcome you and your presentation. As I said, worked with you in a number of forums and have been always impressed and excited and thrilled to learn what you have to share. So if you could please start your slides, and welcome to all of us, and thank you for joining.
Good morning, everybody. Thank you so much, Jane, for those kind words. I will immediately get into the presentation, which really has 3 parts. Some minutes I'll spend on the introduction and then on the individual attributes to COVID, as well as in the communication impact which the DG so eloquently referred to. None of this would have been possible without the incredible collaboration between GCIS and the Solidarity Fund. And this specific research, which we're sharing some of the insights on of today, was specifically funded by them. So that, of course, in itself is a fantastic accolade and support of thought leadership in this country. Slide. Okay, let's see. So a lot of research has been conducted on public perceptions, and you might ask yourself, why is that? And it is simply because perceptions are a moving target, specifically with something as unexpected and new like the coronavirus. It was crucial that as many thought leaders as possible get involved and actually conduct research. Now, we have obviously been closely involved with a lot of these studies, but the important thing was always to track where the differences lie and where the similarities lie. Now, mainly the results were very similar, and that really can be linked back to proper sampling. So whilst the different studies might have different focus areas, as long as the sampling is extremely rigorous and the data collection of very, very high quality, the results should be similar. Now, for this particular study, a half an hour interview was conducted with 2,000 citizens during mid-May to June. So these results are very new and very relevant still to today. Now, when we say that interviews are conducted across the country representing all citizens, this is sometimes a snapshot of what interviewers need to deal with. Now, why is it that we make it so hard for the interviewers, you might ask? And it's simply because it's crucial that when one bases a communication strategy on research, you have to be able to say that all citizens have been included and reflected in their perceptions. So this is an important note. I've just received a message that you are not able to see the presentation. Is that still the case, or can you see the presentation?
I can see from my side.
We can see.
Oh, okay, good.
Okay, Andrea, I've shared it from our side. It's Letitia.
Okay.
Yes.
Okay, thank you. So when we look at the respondent profile of the study, it's important to note that it literally reflects the citizens of our country. So when you look at employment status, for example, you'll see there's 32% working, 31% not working. So that would include housewives, those with illnesses, or pensioners even. So this, if you look at every part of this, really reflects all South Africans. Very importantly, the GCIS has a fantastic segmentation model of our citizens. And it was important that all research uses that as a common platform. So when in the results later we talk about rooted realists, this is what it links to. So rooted realists are primarily rural, mostly unemployed, and they reflect nearly half of the South African adult population. The city seekers are 25% of the adult population, and it's those that are trying to create a new life in cities, in urban areas. Now, they generally are, they've moved, they're mobile, they're in a new environment, and it's really hard for them to establish themselves. Those that have moved into the next level, the safely suburbans, have sometimes found a job. They're mostly in the middle income bracket. It's 6 million of our people, but they're very critical of life in general. Then the metro mobiles are even more settled. They're mainly in Gauteng, Western Cape, and KZN. And the cosmopolitan capitals are probably all the people in this room, professional, mainly employed, mainly in Gauteng and the Western Cape. When we as researchers look at the dynamics of behavior change, it is very important to take a systemic view of research. So this research study focused on individual attributes and communication attributes. But one has to be cognizant of societal dynamics. One has to be cognizant of the actual demographics in South Africa. When we designed the research, we looked at 4 aspects. So if you look on this fan, the blue aspects are the individual parts of a person. How willing are they to be vaccinated? How strongly do they feel able to act personally? What are the reasons for hesitancy, and what is their most trusted source of the vaccine? Only once you have that information can you actually look at the impact and effect of communication. It is also very important to understand how fast new beliefs and behaviors are actually adapted. Now, you will all know this chart or this adoption funnel of new products or new behaviors. Now, if you look at this, you will see that on the left-hand side are the innovators and the early adopters. Those are generally the leaders in society. They will first take a product on board or a new behavior on board. To get from an early adoption cycle to an early majority cycle is very hard, because that's then where the trough of disillusionment is. And that's where, as a country, we are at the moment. So my sympathy to the Solidarity Fund and GCIS, because bridging this gap is very, very hard. But that's why we have this fantastic collaboration going between those parties. We must also consider the spread of the South African demographic. When you consider that we are a very young population, with a large part of the population actually being the youngsters up to the millennials, and those, interestingly, are the hardest to catch. So this is just something important to notice, where, as Jane and the DG referred to earlier, we're now starting to talk to the youngsters, but they are a very hard nut to crack, and they make up the majority of our population. So this then is the context of the research study and of the communication strategy. In summary, I would like to present some of the findings to you, and we'll go into a lot more detail after the summary slide. When we look at the vaccine willingness, as the DG referred to, there's 62% willing to get the vaccine. It would seem, though, that this claim is even in some cases aspirational. So we cannot assume that when there's a 62% willingness, that they will all actually get the vaccine. Then when we look at the agency to act, that's really embedded in the individual nature of every citizen. And to what extent do they take responsibility? Now, from previous studies we've done for the Solidarity Fund and GCIS, we know that as South Africans, there's a very high personal responsibility for health and well-being. But even so, the citizens, a large part of the citizens have very low hope, and a third actually believe the worst is yet to come. Most citizens, 70%, wear a mask daily, which is good. Only a third are aware of the EBDS system, and we'll understand that just now. When we look at reasons for hesitancy, it's really on the very hard level of trust. A third of our citizens just have a general mistrust towards corona, towards the strategies, towards the actual vaccination. 23% are scared of side effects. And then the main reason for vaccination is protecting yourself. When we look at who would you trust on vaccine advice, 43% refer to doctors, then it's the government, health experts, and then the World Health Organizations. When we look at the reach of the vaccine rollout plan, 55% say they're aware of it. The best platforms are news on TV and radio, and on the message recall, there's only a 22% message recall on who actually gets it. So it's a very low message recall. I just referred earlier to 2 in 3 South Africans actually are willing to get vaccinated. But when you split that up, the willingness is a combination of those very willing to get vaccinated and those who are simply willing to get vaccinated. The very willing segment always hovers between 32 and 47%, which is low. It's a low percentage. It's not different to the global patterns, but this is what we have, what we're dealing with in South Africa. So the 20% who are willing still need to get that final bump to actually do it, besides those that are neutral and unwilling. When we look at this segmentation of these citizens, we can see that the cosmopolitan capitals, so those in cities, having jobs, living the life that's probably very similar to most of us in this room, there's the smallest percentage of them are unwilling to vaccinate. The unwillingness lies in the safely suburbans and the metro mobiles. Now, this is the big challenge on the youth, as I referred to earlier. You can very clearly see here that the 18 to 24-year-olds are least willing to get vaccinated. So that is going to present a hurdle to our vaccination drive. Those of 60 and aged 60 and plus are actually the most willing to get vaccinated. So age makes a huge difference to vaccination intent. There was some discussion around gender as well, and you can see that there are differences, but there are not massive differences. When we looked at race, we could also see that there are differences, with the Indian community being most willing to be vaccinated, followed then by the Black community, then the white community, and the least willing community for vaccinations are the colored community. There are also large differences in the provinces, and that's why the GCIS strategy to have provincial communications was so powerful, because we can see that in Limpopo and the Northwest, the blue squares is what you need to look at on the slide. They're the most willing to be vaccinated. The ones in the citizens in the Northern Cape are neutral, and in the Western Cape, we see the highest unwillingness to get vaccinated. Now, we can connect this somewhat to the colored population being so unwilling to be vaccinated. So we're dealing here with trust as well. And in a lot of research conducted last year, we could see that the higher the trust is in our president, the higher the support was and the willingness was to listen to actual communications. Our Minister Mkhize, being a doctor himself, also carried a high level of trust and high level of support of his messages. So we could see that there was a very clear link that if there's trust in government, one would be willing to support the government communications. But the highest trust still lies also with doctors and health experts. So the strategy to let scientists like Professor Karim and a lot of the other scientists speak directly was very powerful. Now, this you might think is a weird slide because we indicate all the small percentages, the long tail of trust, as it were. The reason I included this slide is if you read on the right-hand side, you will see there's 2% of trust in celebrity influencers, community WhatsApp groups, social media influencers, traditional healers, etc. And so it carries on. Now, it's important to highlight this slide since we literally got this result from the beginning of COVID last year. NGOs were often very keen to use celebrity influencers, traditional healers, leaders, etc., as communicators because it worked so well with other communications. With COVID, it didn't. And that was simply something one had to learn and see that it actually stayed the same right through the pandemic, and that doctors and nurses were the most trusted when it came to communications. Now, hesitancy and willingness actually work in different ways. And that's what makes the job of the experts at GCIS and Solidarity Fund so hard. And I applaud them again for having looked at this from such different angles, because the motivations of these citizens are different. When citizens are hesitant to vaccinate, a third of them say, I just don't trust the vaccine. And when you break it down, it has a lot of different reasons behind it. When you look at why people accept the vaccine, it has nothing to do with trust. It has to do with wanting to protect myself and then secondly, wanting to protect others. So it's a very complex system trying to influence this. When we actually look at it in terms of the age groups, you can see on this slide how different it is. So protecting myself is always the highest reason for accepting the vaccine. Last year, we could see that Ubuntu was a big driver of how communities helped each other, supported each other when there were financial crashes in family, etc. It does not extend to actually taking the vaccine for the sake of others, as we can see on the slide. So when our communication programs say, vaccinate yourself because you will actually protect others, it falls on deaf ears. It's not a motivator. When we look at the different provinces, we could see that the highest vaccine willingness is actually in Gauteng, which was also interesting, which again makes it, I think it demonstrates how hard it is to actually communicate to different audiences. And even the TV ads and radio ads, which are so effective, have to be different by province. Now, I've shared some statistics with you this far. Even so, one has to honor the lived experience. And I'm sharing a few slides with you here on the actual, what people say in the different regions. And you can see it's so diverse, you know, and the different sectors, according to the GCIS segmentation model, are very diverse. So that's just for your read later. The actual satisfaction with the vaccine rollout is high, very low dissatisfaction ratings. The registration process, as one would expect, is tricky for pensioners. And then here we go. The youth have data privacy concerns. Just another hurdle that needs to be factored in. The registration across the different regions was also very hard and very different. Now, interestingly, last year we thought that health would be, or the personal hygiene would be a major shift in society, and it has been when one considers the mask wearing. But a lot of the other protocols have shown a very steep drop-off, which is a concern to me. So wearing a mask when I leave home, 72% still do it, but oftentimes that stops over weekends. We also need to consider that all the COVID communications happen within a society that still shows high distress. And the high distress is highest in KZN. Now, this was done before the looting. So you can imagine that this, in effect, was actually a predictor of what could have happened there. Fear levels are very high, the highest amongst the youth, as they have been from the start of COVID, and citizens in the Eastern Cape. So when we look now at the communication attributes, I will go quicker through these slides because I see I'm running out of time. You can see that the awareness of the rollout plan is at 55%. It's highest in the urban areas, 77%, but it's hard to reach the citizens that see themselves as being outside of the system. Now, I'll just go to the next slide here to go quicker. There are also very large differences by province, which one needs to factor in. The citizens over the age of 50 are the most aware of it. This could also be linked to the 60-year-olds initially being the first to qualify for the vaccine. So it affected them more. Now, when we look at the 28% of South Africans that are unwilling to get vaccinated, half of them say that they have little information on the vaccine rollout plan. When one looks at the detail, this is the hardest group to actually communicate with, simply because they've cut out. When they hear COVID, they are not willing to listen. When we look at the actual barriers, we can see it's the side effects. Now, this very clearly indicates that we need a lot more communication around the side effects. We've also, in all this research with the GCIS and the Solidarity Fund, tested the accuracy of the information. And it was quite interesting to see that only 15% of South Africans recall that they need to maintain protocols even once they're vaccinated. So when we group the actual messaging in terms of who needs to get the vaccine, how is the vaccine administered, and why is the vaccine necessary, it was interesting to see that the lowest recall is actually on why a vaccine is necessary. The highest recall across all age groups, provinces, etc., was people over 60 years must register now for the vaccination. Now, what this indicates to us is that it was the first message. People were still listening. It was the most repeated message. Now, this is an indicator that we cannot stop communicating. We have to continue. Now, when we look at this, we can see, as I indicated earlier, that the cosmopolitan capitals are showing the highest recall, and followed by the metro mobiles. We can also see that there's not much of a difference between which platforms are most effective between urban and rural. Interestingly, a small dip in clinic posters for rural, which was unexpected to me. So vaccine willingness is associated with higher message recall. What this means is, if you are interested in the vaccine, if you are toying with the idea of the vaccine, you are open for the communication. That 28% that's blocked off and said no are very hard to get to. The provincial differences we've referred to, the highest recall overall is in the Western Cape, with the lowest recall in Mpumalanga and Limpopo. This is just a different way of showing more detail on that statement. So when we summarize the most effective platform for the different groups, we can see youth is TV and radio news and social media. Social media is most relevant for the youth, for the others not so. Interestingly, pensioners want to see billboards. The rooted realists, more clinic posters, doctors and nurses. And then Mpumalanga and Limpopo, it's simply TV and radio news. So what then are the recommendations? On reasons for acceptance or hesitancy, one has to address mistrust. And on this point, when one looks at lived experience, it doesn't help to demonize those that are not willing to take the vaccine, because it further pushes them away. It is only when those that don't follow mainstream thoughts also feel accepted and spoken to respectfully, that one might be able to get some base for dialogue and change of perception. And then the side effects, which really, with doctors being the most trusted platform, are obvious that they need to do that communication, which leads me to the next point of the most trusted source of vaccine advice being doctors and nurses. When we look at low reach and awareness, this is not new. One needs to actually package the messaging differently by age, by geotype, education, and province. And the message recall, we need to focus on the why all over again. Many thanks. I've run through the data. I hope it made sense.
Thank you so much, Andrea. And I, as I suspected, it would be fascinating. And thank you very much for sharing that with us. We've had a number of questions. If we could please share the slides. We will be sharing slides. I'm not sure, GCIS members of the panel, how the slides do get shared, whether people should put their email addresses to the chat, or whether you will see the webinar. But can I suggest that if you would like the slides, that at this stage you pop your email address into the chat, and we'll do that. We did have a few minutes to set aside for questions for Andrea, but I just wanted to know if there were any burning questions before or whether we should hold those over. If I don't see any questions in the Q&A, but I do see emails popping in. Thank you, everybody. What I would like to reiterate again, 2 points for me that come out of here, which is so important, is the size of the rooted rural population. This is 48% of the population. I personally work in the social grant queues in Mpumalanga, and I've been working in the East Cape. This is a massive population. And if we think that this will be our most difficult population to reach because of where they are and the numbers that are there, this to me is a population that cannot be forgotten. They are normally marginalized and invisible. And particularly my work is with the 60 pluses. So Andrea, thank you for showing us repeatedly the importance of seeing this population and their significance. They are a big population. And then the other point that I think is so important that Andrea raises is trust. And there have been difficult messages about COVID. We've all had to learn our way. We've had vaccines that are brought in that we haven't used. We've had vaccines brought in that have expired. We've had vaccines that have been contaminated. And these are not issues of trust that are aimed at criticizing the South African government. These are issues that have happened in an unknown pandemic with unknown scientific experiences and realities. And I think we have to build on the role of doctors and nurses. Fascinating to see how important they are. And let's work with them and government, the two most important sources that you've identified. So Andrea, thank you so much. And thank you everybody I see there is a Q&A in the chat. Let me just have a look. It's a Dikaledi asking for slides. So we will answer that with pleasure and send those to you. Can I just go on to our next speaker, please, which is Ms. Wendy Kloo, who is from the Solidarity Fund. We are all very familiar with the Solidarity Fund and the work that they've been doing. Just a few words about Ms. Kloo. She has a seasoned reputation of communications executive in the areas of strategy, media, and stakeholder relations, marketing and branding, as well as sponsorship and partnership management with over 12 years of executive management experience. She sounds absolutely perfect for this webinar and for her position in the Solidarity Fund. And thank you, Ms. Kloo, for doing this work with us. I mean, I'm looking at your previous history in SA tourism, global communications, the FIFA World Cup, a number of Brand SA, Lonman, Group Head of Communication at Brand, and then finally working with us here at Solidarity, which I think is possibly your most challenging, but I like to think your most important role. And certainly at the moment, you're the Executive Head of Humanitarian Support and Behavior Change at the Solidarity Fund. You're in charge of the fund's 425 million humanitarian relief efforts in the areas of food relief and gender-based violence, as well as communication and behavior change campaign budgets of approximately 400 million. So thank you so much for the work that you've been doing in the Solidarity Fund. I've been working with the fund and am aware of your work. And so many South Africans are beneficiaries and recipients of the work that you're doing in your fund. So thank you so much for your work and thank you for your time. Can I hand over to you, please?
Thanks, Jane, and good morning to everybody. I think mine is not a presentation, but it's just to, I think, give a little bit more, I guess, context to what Andrea has shared. The research that she just shared is a co-funded and co-partnered project between the GCIS and the Solidarity Fund. And we thought it important as a Solidarity Fund to partner with GCIS to do this work because as you've seen in the research, it is of critical importance and very significant that we don't just effect communication for the sake of communication, and also to not just have a top-down approach to communication. It's important that we listen, and we listen with intent, and we listen with a purpose to respond in the manner that the citizenry is asking us to talk to them. I think it's important as well that as we craft communication in a very unpredictable environment, in an environment that is ever changing, that we collaborate, that we partner, but we partner effectively and we partner meaningfully in ways that are going to be felt by the citizens to whom we are communicating. So the work that we have done with the GCIS is of critical importance. We will continue to work with GCIS on making sure that we effect research that is responsive, research that continues to guide on a much quicker basis the work that we do on communications. And as we prepare as a Solidarity Fund to launch the next phase of our campaign, which is really about addressing some of the issues that Andrea spoke about, addressing the issues of vaccine access, and I think access is beyond communication, of addressing a demand strategy that is really led by the National Department of Health to make sure that on the communications front, we are effecting information and getting out information and listening to people, but giving information that actually responds to the issues that they're raising. It's important for us to have social listening mechanisms to understand what is being reported in the media, as well as to be responsive quickly to some of those issues. It's important for us as well in what we have then garnered from this research that we utilize platforms and channels and influential voices that are relevant in the communities that we work in. And this next part of our work is really going to be working very much on the ground, in communities, in partners that are in the community-based organization environment that are represented at our National Communication Partnership, to make sure that we are present not just through mediated platforms, but through platforms where we can listen, we can engage, and we can immediately deal with some of the issues that people are experiencing. So we're very excited as a Solidarity Fund to work with GCIS on this important piece of work. And as I said, it will continue into the rest of the year. And we are grateful that we have this added mechanism through the research that will help to inform what we do in communications and make sure that we deliver communications that has traction, that is meaningful, but that resonates and is based on listening to the communities that we aim to serve. So thank you. That's it from me.
Thank you so much, Wendy. I was just looking at your, thinking about your surname, and that this really is an elephant-sized task. I don't know how many of you speak Afrikaans, but there's a wonderful Afrikaans expression, "Hoe eet jy 'n olifant?" Happy per happy. And excuse my accent for those of you who first language Afrikaans speakers, but the question is, how do you eat an elephant? Bite by bite. And, you know, if you look at the elephant, you can't even start. But if you start with a bite, that's one bite done. And again, thank you to Solidarity for your funding and support in this area. I'd like to now welcome, I see a number of questions are coming in. I'd like to ask people to feel free to answer them in the chat and in the Q&A questions themselves. We have got a Q&A time at the end of the webinar, but I would like to keep going on to Professor Moshaba next. So if you could just keep your questions coming in, and please feel free to answer them. So Professor Moshabela, apologies for getting your name wrong. It is coming up on my screen, just the first letters. So now, just to introduce Professor Mosa Moshabela, who is currently holding the position of Associate Professor and Acting Deputy Vice Chancellor of Research and Innovation at the University of KwaZulu-Natal. Until December 2020, he was Dean in the School of Nursing and Public Health at KZN. Public health, I think, has become an incredibly important space. It has always been, but COVID has highlighted for us the importance of understanding public health and understanding the issues of health that affect people or the public. He is a chief medical specialist. He's trained as a medical practitioner and specialized in family medicine and primary health care. He completed a master's in demography and health, and has a doctorate in philosophy in the field of public health, with a specific focus on health systems and policy research. Again, Prof. Moshabela, COVID must be really giving you an opportunity to put these into practice. Your research portfolio in implementation science and health system cuts across multiple disciplines and involves the design, implementation, and evaluation of complex interventions in public healthcare services and programs. You seek to improve access, quality, and equity in healthcare in ways that are appropriate for resource-poor settings in sub-Saharan Africa. And I think COVID is showing us the importance, and this conversation about communication is the importance of access, quality, and equity in health care and access to vaccines. You are the convener of the COVID-19 response team at the University of KwaZulu-Natal. You're an advisor to the Department of Health. Professor Moshabela is the chairperson of the Standing Committee on Health in the Academy of Science of South Africa and a chairperson of the committee to evaluate the national health sector response to COVID-19 in South Africa. We're very lucky to have you on this webinar. Internationally, he is a member of the Lancet Commission on Synergies between Health Promotion, Universal Health Coverage, and Global Health Security, and the U.S. National Academies of Science, Engineering, and Medical Commission, as well as a member on the Human Resources of Health in Rwanda and the Global Roadmap Towards Health Longevity Commissions. So, Professor Moshabela, thank you so much for your time, and thank you for joining us. I have a master's in public health, so I feel that the influence and the importance of public health understanding on this virus and this pandemic are particularly important. So thank you for joining us as we seek to address communication by listening to what research is telling us. Thank you.
Thank you so much, Program Director, and greetings to the DG and to other members of the panel and all the participants who are present today. I want to thank Dr. Nala and the team at GCIS for inviting me to be part of this panel. It's very exciting for me to see that GCIS is really making strides in using research to inform the the communication interventions that have to be put in place, and the communication strategy and activities that have to be put in place. Now, I think I've been engaging with COVID from February last year, and a lot of the times, one of the things that has occupied nearly all of my time has been around public health communication. And this is also one area that I have found that we kind of struggled the most. We made a lot of strides and improvements compared to other programs that we have had previously. There was a lot of attention given to communication in terms of COVID-19. But nevertheless, I think that there is still a lot that needs to be done, given the fact that we've got goals that we have to meet. Now, what I'm going to try and do is to try and connect the dots in terms of the research that was presented and what I think are the other pieces that have to be considered. And the main theme of what I'm going to convey to GCIS and to the media and colleagues that are present here today, including other panelists, is that we are dealing with complexity. And when we are dealing with complexity, we have to acknowledge the complexity for what it is. We have to recognize that there's no one person or one department or one stakeholder that can be able to handle that complexity. We have to draw from different strands. There are so many layers. And I can tell you that as a public health scientist trying to communicate information around COVID-19 and COVID-19 vaccines, I have had to deal with areas of medicine and science that are outside of my specialty, just because there were pieces that were relevant. And to give you an example is that I would be most comfortable talking about health systems issues and policy issues, because that's where I normally do most of my research. And that area really brings together different types of research, including both quantitative research, qualitative research, or what you will call social science research, as well as epidemiological research and clinical research. We draw them together. But what I have found is that even though I don't deal a lot with the basic sciences like virology and immunology, when I'm dealing with a new disease as a scientist, I have to go back there to be able to make sure that I use the science that come from the basic sciences, the virology, the immunology, the genomics, to inform what implications that has for patients, which is now at a level of clinical sciences, where you're studying disease presentation and so forth, and treatments and etc. And then use that to inform the disease trends at a population level in terms of epidemiology and population sciences. And then go further to say, what does this mean for the health system as a whole? And that's another layer of program evaluation, health systems evaluation, policy and decision-making and so forth. And then go further to say that, what does that mean for people? And that involves a lot of the social sciences, including anthropology, including psychology, and other kinds of social sciences that become relevant when you're dealing with people. And there is so much complexity in trying to draw from the evidence in all of those disciplines to make sense of the evidence that's coming out and synthesize it into clear messages for people. And for me, I think that it's a demonstration of the complexity that even when you're just trying to communicate the science, you're dealing with so much complexity there in the science alone. But also, there are so many other factors that become important when we are now going to draw from the research to inform communication. And one area that I want to highlight is the issue of who we are speaking to, of audience. A lot of the times, communication can focus on the facts, And I find that, you can rattle out the facts, you can rattle out the percentages, but you may find that those percentages don't mean much. They mean a lot to scientists, perhaps, and they mean something perhaps to healthcare workers, but to the general public, they may not mean much. And so then there is a job, a step in there that requires for us to synthesize those facts and turn them into messages that are clear. And that has to do with the diversity of the audience we're dealing with. I often say to colleagues who say, well, who criticize my communication to say that it does not really say much about the science itself. And I say, look, a lot of the times when I speak, I try and speak to the general public. I take the science, synthesize it, and then use it to anchor the messages that I then develop for the general public. And I think that job is not an easy one. Synthesizing evidence is hard. You've seen the evidence that Andrea presented. It's a lot. And somebody needs to sit down and synthesize it into cogent messages that are anchored in the evidence that's been presented. It's a lot of work. And so we must not take that for granted. And if you make one mistake in interpreting a piece of data, you can then begin to mislead the population or the general public in that. And so there's a difference when we are speaking to the general public and when we are addressing messages to healthcare workers, for example, or messages to other scientists, or messages to policymakers, or messages to implementers and program managers. Those approaches are different, and we need to be clear. And GCIS, in the strategy that is being developed, it needs to be clear who is being addressed here. And as we engage the different stakeholders in the departments, be it Department of Health, be it basic education or higher education, then it needs to be clear who we are addressing and why we are addressing them. On the whole, I think that the Department of Health will be dealing a lot with the supply side of the vaccine program. They'll be dealing a lot with the programmatic issues. And they may deal a lot with the healthcare workers themselves. We have seen the evidence has shown that healthcare workers play an important role. But let's remember, healthcare workers are not scientists. For most of them, they're trained to provide care. They're trained to provide clinical care. But when you're dealing with a relatively new disease like COVID-19, you're dealing with new evidence that is constantly coming out around vaccines and so forth. Healthcare workers need to be empowered with the information that they can then impart to the general population as they engage patients. There is a process that it becomes important in terms of how the Department of Health engages with healthcare workers. And one of the issues that becomes really important there is the timing of information. Healthcare workers need to get information in real time, because the general public is dealing with information that is not only emerging from the science in South Africa, not only emerging from the program, the data that is presented from the program, usually when we get briefings from the Department of Health. They're also dealing with information that is, the general public is also dealing with information that is coming from global sciences, that is coming from country experiences in other parts of the world. That influences a lot of what people think, questions that they raise. And if our healthcare workers are not given information in real time to be able to handle all of those questions, then we may end up with miscommunication. And when we end up with miscommunication, then we end up with problems, as we have seen, especially problems of trust. Now, the issue of diverse audience here becomes important in the strategy that GCIS and different partners involved put forward in terms of who is being addressed and how that information is going to be synthesized and how that information is going to be packaged to be delivered to those people. There's a certain way information needs to be packaged for healthcare workers, doctors and nurses and other healthcare members of the healthcare team. There's a certain way information needs to be packaged for scientists who are relevant. There's a certain way information needs to be packaged for policymakers and program implementers and so forth, people who design programs, evaluate and so forth. Then the general public. And we need to be clear there who we are speaking about. Now, I want to touch also on this issue of, I've mentioned the issue of science, that science is evolving all the time. And we've got scientific information that is coming from outside of South Africa, like we've seen today, which is about perceptions. And we know it's important to do surveys of perceptions, but these perceptions, they change. They're not constant. What was predominant perceptions around April, May was around concerns around the myths of vaccines. Now what we are seeing in the last couple of months, June, July, we are seeing September, we are seeing that people are more concerned with the lived experience. The side effects are mostly lived experiences. And they will raise specific issues, for example, death that is associated with death following the vaccination, taking of the vaccine. So those things become really important to address, to understand that there is changing perceptions over time, and we need to keep track of those perceptions and constantly tailor our communication to the changes in the trends of those perceptions. Likewise, there is changing information in terms of the science of vaccines, and we have to make sure that we track the messaging in line with the changing science that is emerging. Otherwise, our messages quickly become outdated. And when they become outdated, then these are the kind of things that feed into us not necessarily being responsive to the needs of the population, to the needs of society in the way that we communicate. And we've also seen that even in terms of the disease itself, we are constantly seeing changes. You know, the new variants that emerge, they introduce new dynamics around the disease and the disease trends as well. And that needs to be taken into account in our messaging. Yes, we want to influence vaccination, but it's not easy to influence understanding and information and behavior around vaccination without necessarily addressing the understanding and behaviors around COVID-19 itself. And also, but all of those things become layers that have to be considered in the way that we are going to put the strategy forward. Now, let me move quickly to this issue of behavior that we want to influence, or the objectives of what we want to achieve with communication. Communication is very complex, and I have come to realize. And we deal with behavior change from a health promotion perspective. And there are so many layers in there that are important. And the frameworks that we use mean that you must consider the individual, consider people around the individual, consider the context, consider the laws and legislation, a number of things that have to be considered there. But one of the things that we then also have to think about is the fact that when we say that we are communicating information, on the surface of it, we think that we're just giving information out to inform people, and that should translate into comprehension and knowledge, which is also why we can test recall to see how much people recall. But when we are dealing with vaccination, you are really wanting to influence behavior. And to influence behavior, knowledge needs to be translated into skills. It needs to be translated into confidence in the vaccination. So the attitudes needs to change and have more confidence. And also that knowledge needs to then result in behavior change. And if we are lucky, then the person that we have actually influenced need to become an advocate of the intervention that we're looking at. In this case, it's vaccination. So to inform doesn't mean that people will understand. And when people understand doesn't mean that they will retain the knowledge. And also when you've got the knowledge, it doesn't translate into skills. We have to be intentional in how we are structuring, how knowledge then becomes skills. And the skills don't necessarily become into confidence in doing these things habitually. And then we are dealing with issues of behavior change that may have to come from the skills that people have. And so all of these things then need to be put together for the people to then to be influenced. And so the goals of this communication strategy that is informed by the research will have to be very clear, because then that needs to feed into what kind of data we keep collecting. The data that we are looking at has a lot to do with perceptions. It may not have other aspects that we may be interested in, which is why I was saying that there's also data that relates to breakthrough science that people are interested in. There's also data that relates to changes in the disease itself that people may be interested in, and also changes around the program evaluation. We constantly get data that is based on routine services from the Department of Health in terms of what is happening. So we need to be clear how that data then becomes a part of the communication strategy. So we need to say, what are the goals here? If our goal is to reduce mistrust or to instill more trust in the vaccination program or in the interventions that the Department of Health is actually introducing or other departments are introducing, then that needs to be clear. If our goal is to counter misinformation and disinformation and this whole info war, then that needs to be clear, because then you need to think about the strategies you're going to use around that, including considering having to work with fact checkers, for example. And I also just want to say that behavior change is something that requires multiple stakeholders. It's not something that is going to be done only from a health perspective or from a medical perspective. So you need to have different stakeholders from different sectors of society in order to successfully change behavior around attitudes and behaviors around vaccination. And so, and also, again, considering the fact that different players will be bringing in different elements that have to be pulled together. And a department like GCIS might be able to coordinate the different groups that need to participate in this process, especially if the focus really is about addressing the demand side, which is really about the general public and engaging the general public, either through media or through other forms of communication. That will depend. Now, I want to finish off my summary here with the issue of the sources of information. Information can come from different sources, but we live in a current context that deals with that is experiencing a lot of trust deficit. There's a lot of mistrust. A lot of people do not trust the political principles and do not trust government, and it's been stated in the report that we've received. And this affects how we move forward. A lot of people don't trust the media because they think that there is an agenda the media is driving. And this becomes important in terms of how we build trust. A lot of people don't trust scientists as well, because then scientists are sometimes conflicted in terms of interests. And this makes it very difficult in terms of how we communicate. And you can look at that issue of mistrust on the whole in terms of the sources of information that we are then going to use. There is the highest trust, as has been indicated, around healthcare workers, doctors and nurses and so forth. But those healthcare workers also are members of society. They have their own religious beliefs, their own biases, and they may not get all of the information that they need. And if there is a bad experience with healthcare workers or doctors and nurses, that can influence the trust people have, especially around issues of side effects and so forth. So in some instances, for example, you find that a healthcare worker picks up that a patient may be at risk of a certain side effect, but does not take it seriously, and then there is an adverse reaction that can destroy trust. So here we need to carefully think about what are the sources that we are going to be using and to state them and be transparent. Building trust will be very difficult, but the sources of information become important. Likewise, there will be sources of misinformation and disinformation. GCIS needs to decide how this is going to be dealt with. It becomes important for us to decide whether we are going to actively counter disinformation and misinformation or not. In my view, I think that we need to, because there is a lot of coordinated effort in terms of misinforming the public. And this has direct implications for people's lives. I therefore want to wrap up by saying that, as I've indicated, there is a lot of issues we are navigating in the way that we are communicating. There is diversity in the audiences. There is diversity in the science. There is diversity in terms of the sources of information. There is diversity in a number of ways that introduces layers of complexity. And my appeal is that we do not ignore this. There is a reason why the data that's been presented looks complex, but it can be synthesized, it can be simplified. And my appeal is that we do not reduce it into something that is too simple at the expense of the respect for this diversity that needs to be honored, including the fact that there needs to be coordination across different sectors and across different levels. And I'm looking forward to any further engagements on these issues. Once again, thank you for the data that's been presented. There is a lot more data that needs to be considered and synthesized, but this is a good indication that we could be moving in the right direction if we anchor our communication in the evidence that exists. Thank you so much.
Thank you so much. Thank you, Prof. Boshebela. And I have been making notes while you've been speaking, and I understand and very clearly now how you got to Prof, because there's a lot of stuff I've been writing down. I just wanted to say your key messages that to me were, who is our audience? Who are we speaking to? And I think this brings in exactly the role of the media. And when I talk to people and when I present or ask people to engage with me or work with me on a number of projects, I like to refer to people as the experts of their environment. So no matter what your position is academically or scientifically, you are an expert of what you do. And the media are the experts here of the target audience. They know who they're speaking to. They know who's reading their media. They know what needs to be said. And we need to give them the facts and the information for them to translate from GCIS into messages that can go out to the community. And this brings in, again, the issue of trust. So I think the issues that have come up is the role of trust, the role of media, the role of communication. Who are we speaking to? And then, Prof, you brought in my home study, my home place of behavior change and social behavior change and communication. So knowledge doesn't translate into behavior change. We know this. We've seen this. Let's remember that we've been through HIV and AIDS. We know that people know they shouldn't use that they should use condoms, but we also know that people don't. So what are the skills? What is research telling us about what people need to translate their knowledge to, in this example, to get a vaccine, to actually getting a vaccine? And this shifts to what we're trying to create here with all of us using research, using the media, is to create a new norm. What will be the new norm? It is new for adults to get vaccinated, but now we need to make that a normal behavior. So thank you very much, Prof, for your thoughts and for bringing in this issue of what do we need to do to shift behavior. And I think Christopher's brought this up in the chat. And thank you to Tasneem, a colleague at GCIS, for responding. But communication can't work alone. And we need multiple stakeholders and community members, researchers, scientists, media, partners to bring this around. I've got a couple of questions that we have got a bit of time that I'd like to ask our panelists to respond. Andrea, we've got two for you. The one is, how do you attribute the colored community's reluctance to vaccinate? And that would be interesting to know. The second is, how big an issue is fake news? I mean, can it keeps coming up. Is fake news contributing to vaccine hesitancy? If we look at the extent of social media and fake news, how many people are actually seeing it? What is the message recall, I suppose we could say, on fake news as opposed to correct news? if you could answer those two for us, Andrea, and if you've seen anything else pop up in the chats, I'm going to scroll through them now in the questions that you would like to answer at this time. Please go ahead and address any of the questions that you asked. I would also at this opportunity like all the panelists to be able to respond. And if you've got contributions to make, please, if you could assist in answering the questions. As I said, we're all experts in our fields, and there are a number of questions that have been directed to people or to questions that I believe there are people here who can answer. So, Andrea, let's kick off with you.
Okay, to your first point, in terms of why the coloured community is less willing to be vaccinated, in other studies we've seen that the coloured community is less likely to trust government. So the vaccine and COVID communications, the official communications, have mainly been from government. Business has not been as visible. Government has mainly driven the vaccine messaging. For that reason, I think when the coloured community has less trust in government communications, they will be less likely to actually believe and support the vaccination drive. Then on your question with regards to fake news, it is an old communication principle that the less official communication there is, the more grapevining comes up. Now, fake news is not always grapevining, but it falls into that category. Globally, it was quite, COVID was new for everybody. So there was less official communication than there just simply wasn't, because it was new to everybody. Everybody had to get their bearings. And that's where often social media stepped in. And fake news is not just relevant to this topic. It's part of society at the moment. So it really needs to be managed. I don't know by whom, but general communication in terms of checking your sources. I am not convinced that fake news has such a big impact anymore. But that's my opinion. I don't have data on it as far as I know for the minute, but I will look. So thank you very much.
Thank you so much, Andrea. Another question I've got here, and perhaps a GCIS a colleague could comment on this. The GCIS was part with a significant budget to drive a national campaign. And has this been repeated this year again? And is there greater interdepartmental cooperation in centralizing budgets to maximize impact? Is there somebody from GCIS who would be able to respond to this? In my work, and I think this is something that we should have in our messaging, is that interdepartmental work is so important, and interdepartmental cooperation is so important. And yes, we have been saying that health needs to drive the messaging, but health cannot drive this all on their own. Health needs the support of departments of basic education, science and technology, higher education, as a number of departments, agriculture, as we go through the different communities and stakeholder groups in South Africa. So is there somebody here who would be able to answer this on the chat or live? And sorry, I can't see hands because I've got this chat open. If someone could come in.
Jane, there is a question from Portia Siroti and another question from Wendy Mbolekwa.
Are these on the chat, or could you read them? Tasneem, I see your hand up. Could you read them to me, or are they on the chats or in the question and answer?
They are people with their hands raised.
Oh, please, can you, sorry, hands raised.
Yeah, Jane,
Yes.
thanks. I think it's a good sign that there are so many people willing to engage And it seems like many of the participants are using both the chat box and the Q&A. And of course, there's many questions. Some of those questions are not it's not possible for us to answer in this forum, as this forum has been put together to specifically look at research and research findings. So there are some issues that we're not going to be able to answer specifically on policy issues. And I think it would be a useful thing to look at setting up another webinar where we will be addressing some of those policy issues. But if I can, I will try to assist with at least 2 of the questions that you've directed to me. One of those is from Martina, and it's about the budget that GCIS did obtain. I'm not sure that I would call that budget a significant budget. It certainly doesn't meet the standard of the type of campaign that you need to the campaign funding that you need to run a campaign like this. But there was an application to Treasury and it was successful. So we have got a budget of 60 million Rand, which is known. It's something that we report to Parliament on. And what we're doing with that is we're trying to reach as many people as possible, including the target markets that have been identified in the research as the results come out. We're using multiple platforms, and it has a consistency from 2020 to 2021 in the Stay Safe campaign rollout. So that's the one question. The other question is that the one about fake news. Andrea did address it somewhat. But I also wanted to say that wherever GCIS and government partners are informed, or it comes to our attention that there is something that is fake, and misinformation and disinformation are 2 different kind of things. But sometimes there's information that comes out that is clearly fake, and its intention is not necessarily bona fides. And there we work with our partners to stamp it fake. It's quite prominent on the website, on the government website, as well as the sacoronavirus.co.za website and government departments. Unfortunately, fake news is not a new phenomenon. Just the platform which works much faster, that is social media, is new. But, fake news has always been around, and, the proliferation of fake news does seem to rise and stem with all sorts of other issues in the environment. We do what we can, and we do try to make sure that amongst the partnerships that we have, both inside government as well as outside government, amongst business, the labor unions, as well as civil society, that we try to address fake news as soon as possible. And then the last question that I will also try to address that you've referred me to is about the partnerships. It's part of the question, I think, that Martina asked. And I think it's important to note that COVID has brought about the urgent need to consolidate our partnerships, and our partnerships within government cut across the intergovernmental spheres of government. So we have a partnership with national departments, provincial and local. And we also have a partnership, as I've mentioned before. All of these partners meet once a week in different fora. We have partnerships with business institutions, with labor federations, as well as with civil society, organized civil society. And it assists us to coordinate both the messaging as well as the rollout of communication where necessary. And it certainly does help us to reduce the amount of misinformation in the environment. The last point that I think I must make is that South Africa is not in a unique position. The kind of challenges we find are challenges that exist the world over. Even the scientists are learning new things about the virus day by day, and also even our communications agenda as well as our research is also in a position where things are not static and conditions change, and we are finding new and different ways in which to reach out, and new and different issues that we need to reach out on. I hope I've addressed some of those questions, and we can take some a little bit later on, time permitting. Thank you very much.
Thank you so much, Tasneem, for your contribution to that. I've got a question here for Prof. Moshabela from Michael Curran, who is at GCIS. And I see you've answered it in the chat, Prof, but I'd like to ask you if you could answer it in the public forum, because I think that is very important. So the question is, leaving aside logistical and challenges that the rooted realists are experiencing, whether they can get to vaccine sites or not, what messages should we consider for this group to undo some of the trust deficit related to the myths and the well, as the DDG says, crazy talk we've had on social media, especially WhatsApp. So, Prof, what would you do in particular aiming at this rooted realist group and of how to address vaccine uptake or increase vaccine uptake in this space? If you could just speak to us about that. I know you have responded, but it would be great to hear your thoughts.
Thank you so much. I think that what I try and do is understand the audience and basically take the science and tailor it to the audience that I'm dealing with. And I think that it's an important part of effective communication. And I also think that the messages have to be anchored in the realities of the audience you're dealing with. I worked in rural areas for 10 years, and we always said that healthcare in rural areas, succeeds because of relations. People are very relational. And we knew that the billboards are not really going to work. And of course, I'm generalizing now because, as Andrea said, that different age groups may have different reliable sources available to them. But on the whole, people who are anchored in lives of hardship and people who are in rural areas, a lot of the times they feel marginalized and ignored by the system because of their struggles. And so that already sets the tone for how you engage. And so it becomes difficult to just simply engage them from a distance, or for them to trust sources that are far from them. And without generalizing, I think that it's important to make sure that the media is involved, radio especially, but also TV can be important. But really, I think that and we've seen this example from Limpopo and the Eastern Cape, what's important is to engage face-to-face with people who are rooted in realities. And the face-to-face engagement basically help to show respect and dignity, and to build rapport and relationships, and also to ensure that there is an opportunity for clarification, especially using local languages, as well as for them to know that if there is a problem later, they know who to approach, who to go to. And that's why the role of healthcare workers become important there. But we've seen it, people using community health workers community leaders, traditional leaders, religious leaders to engage. And it's really, the way I understand it is that it's really designed mostly to ensure that it leverages the relationship aspect. For the youth, for example, people who engage on social media, they don't care so much about personal relationships. They have their own way of evaluating the evidence or information that they receive. But when you're talking about groups that are in this sort of environments and communities, then relations become important. And I think that we have to respect that, especially because if people constantly feel like, there are levels of unemployment, poor service delivery, all of that build up to the challenges that we face or the mistrust that we face that we have to work with. And so you may not undo all of it, but you could leverage the relationships that are already there and demonstrate that you care by showing respect and approach them in a dignifying way, which is why I think that one needs to really think about the audience and understand the audience and tailor the approach, not just the messages to the audience. And also when you come up with messages for interventions, those interventions have to accommodate their realities as well. So if you're going to suggest that they do something, then it needs to be something that's feasible for them. So we can't really completely ignore their realities, Michael. We need to make sure that they become part of the approach that we use. And I say this because we've got concrete examples of efforts similar to this from Limpopo and the Eastern Cape. Thank you.
Thank you so much for your answer, Prof. And this ties into a question that Akona had asked Andrea, was what did the research find was the reason why South Africans still don't know why they should get a vaccine? And what can be done to remedy this? And I'm going to ask Andrea to respond in person as well as she's responded on the chat. Andrea, if you could just give us your response. And I'd like to add that, you respond and then I'll add. So please go ahead.
So there were, two parts which we didn't discuss in today's research, which were about a hope index, as well as about emotional, financial, and other distress, which we measured in all communities across the country. And the emotional distress is exceptionally high. It's an average of above 50%, which means that half of our citizens are under emotional distress. Now, if you are on continuous emotional distress, it's like post-traumatic stress disorder. You are less able to perceive messaging and to deal with stressful information. And the 28% of citizens that we saw are unwilling to be vaccinated, are unwilling to even listen to COVID messaging, which makes it very hard to reach that segment. We also saw in the Hope Index that the Eastern Cape, just like Prof. Mosana said, the hope is very, and then it's even more difficult to motivate people to get engaged in behavior change. So those are systemic issues which all communication strategies further tasked to deal with, which makes it even harder. So I believe that citizens are not able to even listen to an argument around why a vaccine is important. It gets too complicated. And as many listeners have, with COVID being such a new thing, there have been learnings also in the way we message and the content of the messaging. But that has made it, made many citizens just push it away.
Thank you, Andrea. And I wanted to add the financial stress that South Africans are under. And the option of whether you use money that you've either earned or received as a beneficiary to go and get a vaccine, or whether you use that money to buy food. And, if we think that it's over 6 million people in South Africa have applied for the COVID relief grant of 350 Rand a month, a 50 Rand taxi fare to access a vaccine will make it impossible to get. So I think in light of Portia's comment about Maslow's hierarchy of needs, how can I care about safety when I cannot feed myself? So I think what was also very interesting in your research was that people, the spirit of Ubuntu is not applying to getting a vaccine. I'm getting it to protect myself. But I think what is so important is that if I can't feed myself or I can't clothe or employ myself, I'm going to delay getting a vaccine because of the other conflicting interests. And that has come out in research that I've been involved in the SAMRC and the HSRC, speaking towards. I see Tamar's question now that the poverty challenges. Tamar, we are looking at that, and I think what we should be doing with Tasneem is taking these questions and working a second webinar to answer a number of these questions that are not necessarily research related, but I think very, very relevant to the uniqueness and to the fact that we're experiencing this pandemic for the first time in a modern world, or a pandemic like this for the first time in a modern world. And I think we should certainly have a second or third webinar to address these things. And I'd just like to take this opportunity to thank GCIS for putting together this opportunity for us to engage with everyone. So Tamar, I'm happy to discuss that with you, and we can certainly look at it. But I think looking at the time, I'd like to close this. We've got a few minutes left. I think the word that's come out repeatedly through this has been trust. And who are we speaking to, and who is speaking to who? And I think this is the message that we need to take forward with the media. You are trusted resources in your communities and the people you speak to. People would not listen to you or buy your newspapers or read your articles if they did not trust what you had to say. We need to find a way to translate your role as sharing trusted information with the people who are speaking about trust, and that would be the healthcare workers and the doctors and nurses. And I think this is very important, that we look at who are speaking and who is listening. And often I refer to who are the gatekeepers or who are the enablers to behavior. So, we need to identify who are these people and then what we can do with them to shift a knowledge, like Professor Prof says, about shifting a knowledge into a behavior. So in terms of sort of wanting to conclude, I'd like to just say that the issues of trust, the issues of media, and the issues of what we like to call behavior change are crucial to this conversation. And we need to go beyond knowledge to shifting and creating a new norm. That new norm would be that it would be normal to get vaccinated. Behavior norms in health behaviors have happened in the past. It is now a new norm not to smoke in public places. It's a new norm to smoke outdoors. It's a new norm not to smoke with children. It is possible to shift norms. We've just got to find and identify the ways to do it. And I think webinars like this, engagement like this with communities of researchers, experts, and with the media yourselves, give us this forum in which to develop and find a way to translate the norms of only children getting vaccines into adults getting vaccines. So I'd like to thank all of you for attending. I'd like to thank in particular the DG for her remarks and for providing this opportunity through her staff and colleagues, for giving us an opportunity to engage with all of you. And thank you to the colleagues on GCIS who set up this webinar. And thank you in particular to our guest speakers, Andrea, Prof and Wendy. And thank you to all of you for joining. And just please we've got your email addresses. We will share presentations as requested. And please do keep engaging with GCIS and ourselves. Thank you to all of you.